My name's Bec Doyle and I am a nurse researcher here at Queensland Children's Hospital, and I've been a member of our HREC for about 6 years, I think. And today we just want to present some work that we're looking into on multimedia aided consent for research projects. So here at Queensland Health, Children's Health Queensland and UQ, we acknowledge traditional owners of the land. For us in Brisbane, it's the Yagara and Turrbal people, and pay respects to elders past, present and emerging. So I'm preaching to the converted. I know that an integral principle of good clinical practice is to obtain prospective informed consent. And in paediatric research, consent is often obtained by parent or legal guardian. The consent process is intended to protect the rights of potential participants, and participants have the right to autonomy to make their own decision about taking part in a trial. They also have the right to justice, beneficence, and non-maleficence, and that is to be treated fairly, to be treated with their best interests at heart, and to not be exposed to harm. But informed consent supports these principles and is intended to protect these rights, not as a tick box, as a process. So for participants to truly elect to enter research voluntarily, they need sufficient information. They need to understand all the processes and activities of the project, including how their data will be collected, stored and disposed of. They need to know the risks of the research and also whether there'll be any benefit to them directly. They also need to know the implications of their participation, and this can be varied from what their time commitments will be to whether their lifelong implications of finding out unexpected information. To do all of this, they need to decide without any coercion or pressure and within a reasonable time to consider the information and ask any questions that arise. So that's a lot. It's a lot that we expect of parents, and especially in paediatrics where parents have a child or a baby that is sick or injured. So what are some of the barriers to informed consent that we know exist in paediatric research? So parental distress, it can be overwhelming and frightening and stressful and an uncertain time for some parents and guardians. And this can impact their decision-making capability. Literacy level is a barrier. So some written information is pitched too high. 44% of Australian adults read at a literacy level of 1 to 2. Reading level of 1 is a reading age of 5 to 9 years old, and a level of 2 is under 15 years old. Health literacy is another barrier, and this is different to literacy. You can have low literacy level, but good health literacy if information is presented in an easy to understand way, so with diagrams and lay terms. Culturally and linguistically diverse participants, 1 in 4 Australians were born overseas and 20% speak a language other than English at home. Excluding these participants from research because they don't understand an English consent document is unethical and not representative of Australians. Sometimes too much information is provided, and this might be typical of a commercially sponsored trial of an investigational drug. I call them the butt covering documents that list every possible side effect and scenario. No one is going to read a 50-page information document to consider participating in a research project. So how do we make sure that consent is informed and potential participants actually understand the information that we are giving them? One approach that is showing promise is the use of digital multimedia as an adjunct to the consent process. So digital multimedia has several advantages: improved comprehension, where digital multimedia leverages the pictorial superiority effect, where individuals remember concrete items more readily when presented as pictures rather than words. Digital multimedia can tailor information to the individual participants' learning styles and information preferences. And this can enhance the amount and delivery of information to meet individual participants' information needs. Videos can also be presented or translated into other languages, making the project potentially more inclusive and accessible. Multimedia-aided consent also standardises information, so digital multimedia can ensure that all participants are receiving the same information in the same way. This can reduce the risk of inconsistencies or biases in the informed consent process and avoid coercion. And multimedia aided consent is flexible. So digital multimedia can be accessed at any time and from any location, which can make it more convenient for participants to review the information at their own pace. A process we've used recently in several clinical trials was to develop a short information video for participants to use in conjunction with written information sheets. There's a QR code up there of one of the videos that we've recently made. Feel free to watch it. I should have subbed it out for one that didn't have me in it. The process involved writing a script and aligning the text with proposed images to accompany the dialogue and music. The transcript was then approved by our HREC, and filming and editing were provided by our university partner. The result is a 3-minute video clip that covers aspects of the trial with voice, simple text, photos, and diagrams. It also reinforces the voluntary nature of consent and prompts the viewer to ask questions and discuss further with health professionals and other family members. It's designed to be viewed in conjunction with written information sheets and face-to-face discussion with the research team, and it certainly shouldn't be used as a replacement. So where to next? One of our videos is in the process of being translated into subtitles. Study sites searched the use of translator services in the study cohort to establish the most commonly spoken languages, and those will be prioritised as text to accompany the video. In the future, we may be able to consider spoken language incorporated into the video. We would also like to explore making the videos culturally appropriate with the addition of words, images, and music. We've received a small grant through UQ to evaluate user experiences of the use of digital multimedia. This project will use interviews of researchers and HREC members, and we would like to extend it to parents and guardians. It would be great to involve consumers in the development of multimedia packages. What do they think is important to know? How do they think it should be delivered or presented? And there is, of course, the potential to expand the process into clinical consent and other areas of health literacy. This is an inclusive and accessible way to deliver information, and the way consumers learn and gather information is changing, and we need to adapt our resources to suit. Thanks.
Apologies, I was on mute. I was talking. Thanks, Beck. That was an excellent talk. Now my computer's doing that wheel of death thing, so just bear with me. I'm going to keep on talking, so hopefully you can hear me. Excellent talk. Thanks for sharing those resources. It looks like there's been a lot of thought put into creating more palatable consent methodologies. There's a lot of favourable comments in the chat. One anonymous attendee has asked, are actors used to film these videos? And this is actually something that came up with one of our HREC members the other day, whether or not actors or members of the team were being used to make the videos. And I could see that you were in one of the videos, Beck. Is that correct?
Oh, can you hear me? Sorry.
I can hear you now. Yes. Was it your, so you're using your team to be part of the consenting videos? Is that correct?
Yeah, at the moment, the funds we had were limited. It would be great to use actors, but we had to use ourselves, which is a little bit substandard. But yeah, I agree. Actors would be great, and having kids involved would be even better to get consumers to tell the story, I think.
It would, but I also think it kind of goes to that idea that consent is a lot about trust. And if you ask consumers or you ask patients why they consent to a trial, and this came up at I think yesterday, is, you know, people are taking part in them a lot of the time because they trust their doctors or they trust the team that's working with them. So it's probably in one way not a bad thing to have your faces there, the people that they trust giving them the message. So